If you've spent any time on social media lately, you've seen it. Microdosing your GLP-1, a tiny fraction of the normal dose, a lower price tag, a celebrity telling you it worked for them. I want to walk you through what microdosing actually is, why it's being marketed so aggressively right now, and what the actual dose data shows us. Because for most patients, I think this trend is a recipe for disappointment, not results. First, let's define it, because the marketing blurs this on purpose. A microdose GLP-1 is a dose well below the starting or maintenance doses studied and approved for weight loss. It's not an FDA-approved regimen, or any approved regimen for that matter. There's no approved microdose indication for semaglutide or tirzepatide. Every microdose protocol you see online is off-label by definition. And most of what's being sold as microdose isn't from any scientific protocol. It's a marketing protocol. Here's the part that bothers me most. This isn't just patients finding a strategy that works for them. This is, in large part, a business model. A low fixed dose is cheaper to produce, easier to sell at a low monthly price that's attractive to a telehealth company's margins, whether or not it's the right dose for the person buying it. It's also being marketed to people who don't really meet the clinical criteria for these medications in the first place. People who aren't dealing with significant overweight or obesity or a weight-related condition, being told they don't need to start on a GLP-1. None of that is about finding your effective dose. It's about selling a price point. Now, let's look at what actually happens from the clinical trials, because this part isn't a matter of opinion. Across both semaglutide and tirzepatide, the trials consistently show a dose-response relationship. Higher doses on average produce more weight loss than lower ones. The starting doses in these medications were designed to reduce side effects during the ramp-up period. They were never intended to be the final destination dosage. In the tirzepatide program specifically, researchers looked at whether the lowest dose study was even worth offering as an ongoing option, and found that only a very small minority of patients on that low dose reached a clinically meaningful weight loss target, compared to the large majority on the higher approved maintenance doses. That's not a knock on lower doses in general. It's the reason the low dose was a starting point on the way up, not a place most people were meant to stay at. Here's what I've actually seen treating patients on these medications. Every single person has a unique dose where three things are true at the same time. They're eating adequate calories and protein, they're losing weight consistently, and they're not dealing with significant side effects. For a small number of my patients, that dose really is low. But for most patients, it's a moderate dose. And for some, it's the maximum labeled dose. And that's exactly where they need to be to get the results. A one-size-fits-all microdose for everyone approach ignores all that individual variation. It's treating a personalized titration process like a flat subscription tier. I don't want this to sound like lower doses are never appropriate. They absolutely can be, when they're chosen for the right reasons. If a patient has a significant GI side effect and lower doses where they tolerate the medication and they're still losing weight, that's the right dose for them. If someone has reached goal and we're using a lower maintenance dose as part of a structured weaning program off the medicine, then that's individualized medicine. The difference is intention. Is the dose being chosen because we've watched your results and your tolerance and landed on the number that works for you? Or because a fixed low dose was the product being sold to you from day one? If you're considering one of these programs, a few things should give you pause. No physical exam, no labs, no individualized titration plan, no real monitoring over time. Also, watch for marketing aimed at people who really don't need to lose significant amounts of weight. They're looking to get as many people on this product as possible. That's a sign the product is being sold just to expand the customer base, not to treat a diagnosed condition. In my practice, dosing isn't a menu tier, it's a process. We start where it's clinically appropriate for you, and then we titrate based on what we're actually seeing. Are you getting in enough calories and protein? Is the weight coming off consistently? And are the side effects manageable or not existent? We adjust from there, up, down, or hold, until we land on your effective dose. For some patients, that does end up being low. For most, it's moderate. For some, it's the maximum dose. The goal is never to guess a number in advance. It's to find the one that actually works for you and works best for you. So, is microdosing smart or a marketing trap? The honest answer is it depends entirely on how you got to that dose. Chosen deliberately based on your response, your tolerance, a lower dose can be exactly right. Sold to you as a flat default because it's cheaper to produce, it's likely to leave most people underdosed and having under results. Your weight and your health deserve more than some marketed business plan to sell more medication. It requires a doctor or trained healthcare provider to understand you and what medication and dose is appropriate for you. Taking medication is serious, and a billboard or TV or online commercial is not the care you need. This is Dr. Greg Oliver. Thank you for joining me, and I'll see you in my next video. So long for now.